So, so anyone can tell me what is the immediate thing that should not be done when we have an extravasation? So when someone reports to you there is an extravasation, you're seeing there is probably an extravasation. What should be done? We should, yes, very good. Stop the IV line. So you should stop water so that further fluid does not go in. But should you remove the IV line immediately or you should not remove? Very good. Stop the IV line, inform doctor. So there is a natural tendency for everyone to remove the IV line immediately. So whoever has gone in, at least you try to aspirate whatever you can, at least even zero point 0.5 ml, zero point 0.3 ml drug, if you could aspirate that uh, and then remove the IV line. So subsequently, we have to do either a warm compress or a cold compress, any one thing. So normally it is easy to remember. Vincristine is V, warm is W. So V and W are close in alphabets. So vincristine, warm compress. And doxorubicin, cold compress. C, cold, D, doxo. So CD are close. So doxorubicin, cold compress, vincristine, warm compress. Because we want to dilate the capillaries. If you keep warm compress, the capillaries will be dilated. The drug will go into the capillaries and not remain in the soft tissue. And then, of course, by doing all this time, you will inform the doctor. We will do some specific antidote measures. For example, vincristine, we have hyaluronidase. So it's a specific injection which we will infiltrate around the wound so that the tissue damage is prevented. For anthracyclines like doxorubicin, daunorubicin, the DMSO. DMSO is a chemical which can be applied topically. DMSO topical application. So these are all the practical points. The most important thing is we never remove the IV line immediately. Always elevate the limb for warm or cold. These are the most common points to be noted during an extravasation. That's great. So, so anyone can tell me there is a child with post chemotherapy 1 week after an intensive chemotherapy coming with 104 degrees fever. You are in the ward or you are in the ER. There is 104 fever and the child is having chills, significant chills. So the mother is saying, I have given paracetamol 2 hours before, it is not helping. So what is to be done next? What is the route of paracetamol that you will prefer now to reduce the fever? Anyway, we have to start antibiotics. So for reducing the fever, paracetamol through which route you will suggest? Okay, someone has answered as sponge bath. Yes, very good. Very good. So oral paracetamol, yes, very good. But yeah, the mother is very anxious and the child is vomiting. Oral is not going to help. Then what is the next option? So what are you going to do with high fever? Child is vomiting. So what are all the other routes of paracetamol that you give during such a high fever? Very good. So IV and suppository. Yes. So these are all the other two options. Perectal. Very good. Very nice. So these are the other options that we give. But in children, immunocompromised children, and in children post chemotherapy, where you anticipate neutropenia, we will never use a perectal suppository. That has to be learned at any cost. Not only you don't know the counts when the child comes to the ER, you don't know the even if 2 days before they have done a CBC and the counts are normal, it could have dropped significantly in 24 hours, 48 hours. So anyone in oncology, the children, never use a suppository. What will happen is, as you push the suppository inside, you're stimulating the rectal mucosa, and there can be some mucositis also, and it will eventually trigger the mucosa, and the mucosal bacteria will get translocated. That is a very significant concern. So we never use anything invasive in immunocompromised children, especially in febrile neutropenia. Never, never ever do a suppository. So we give oral or we give paracetamol IV, and of course, taking blood culture and starting antibiotics as early as possible is the most important thing that we need to do, because your paracetamol is only going to reduce the fever, not the bacteremia inside. So culture at the earliest, the golden hour is usually 1 hour. It's told to be 1 hour, but by the time the patient reaches you itself, usually it's more than 1 hour, because they have to start from their home, come to you, which itself is going to definitely take minimum of 30 to 45 minutes. So we can't keep 1 hour from that time. So at the earliest is the best possible answer.
Last 1 minute.
Hi, ma'am. Sirisha, ma'am. Good evening.
Hi. Good evening. Sorry about the technical glitch that was ongoing for some time.
Sirisha, ma'am, your voice is a bit interrupted.
Ma'am, you are muted. Can you unmute yourself?
Yeah. Can you see me now? Hi.
Yes, ma'am.
Yeah. So I'll share the screen. Okay. Is it visible?
Yes, ma'am. Just you have to put it in a presentation.
Slideshow. Yeah. So sorry all. Actually, it took some time before we got in with because of the technical problems. I'm Dr. Sirisha, senior consultant in Rainbow Children's Hospital in Hyderabad. So today we are going to discuss a very important part of our learning aspect, that is oncological emergencies. Before we go into oncological emergencies, sorry, Dharani, can I go ahead and start? I've just started. Dharani, are you there? That's okay. I think we should proceed. So before we go into oncological emergencies, let us briefly look at what is the importance of oncological emergency in treating the children with cancer, and what is the incidence. So many of you must be aware, the cancer incidence in children is increasing day by day. Malignancy is the second leading cause of death after infections in our country. Of course, first is like accidents, then infections, then the malignancy. All over the world, also the trend of oncology cancer cases are increasing. Currently, we have a burden of almost 50 to 60,000 new pediatric malignancies adding to the existing pool. That is what is the burden. So, and if we look at the spectrum of diseases, we all know that most common cancer is acute leukemia, followed by brain tumors, followed by solid tumors. And most of the oncological emergencies and acute care is required mainly for acute leukemias. So let us look at various oncological emergencies and what is the importance of it and how to treat it and what is the impact of that particular emergency in the long-term outcomes. Let us go ahead and see in detail. I think someone is raising the hand. Are we going to address the concerns then and there itself, questions? Or
Sirisha, ma'am, hi.
Hi.
Hi. Good evening.
Hi.
Your sessions, ma'am. I'll request all the participants to post their queries and comments in the chat. We'll take up everything at the end. So
Okay,
we'll hand over to your team. You can introduce your team and we'll finally have question and answers.
sure, definitely. Yeah. So we
Thank
are
you, ma'am. Over to you.
Yeah, sure. So we are going to discuss from our team, like, me and Dr. Varshini and our specialty oncology and BMT specialty nurse, Sister Vijay Lakshmi, where three of us are here. So I'm going to talk about few oncological emergencies, like tumor lysis, febrile neutropenia, and seizures, various causes of seizures. And Dr. Varshini is going to cover some of the topics. And Sister Vijayalakshmi will give nursing aspects at the end of each talk. Like each talk, we are trying to limit it for 5 minutes max, so that we can discuss more at the end. So these are the various oncological emergencies. Superior mediastinal mass SVC syndrome will be covered by Dr. Varshini, so I'm skipping that. Even cord compression she is going to cover. So I'm skipping that. Let us move to a case of a typical example of tumor lysis. So what is tumor lysis? Tumor lysis is a death or breakage of a cancer cell. Whenever a cancer cell breaks, it's an actively dividing cell. Multiple cells are there. It's huge in number, whether it is a white cell or a tumor. So whenever it is actively breaking or dividing, it is bound to release certain electrolytes into the body, which causes dyselectrolytemia and causes multiple problems, which we will see in a minute. So that is the tumor lysis. This tumor lysis typically can start even before we start the treatment. At the time of presentation itself, child can be in active tumor lysis, or it can start even after starting the treatment, which is mostly the case what we see in our general practice. Like, generally tumor lysis starts after we start the treatment, but it can happen, very well happen even before as well. And if you divide the cancers into different risk categories of tumor lysis, the highest category is like, high white cell count, ALL, Burkitt's lymphoma or leukemia. These are more prone for tumor lysis. Then comes the in intermediate risk category, your normal count ALL or AML comes in intermediate risk category. Low risk category, like, usually solid tumors who don't require supportive care for the tumor lysis. So I think that part is clear. Who is more prone for tumor lysis and what is tumor lysis? Then biochemical definition of tumor lysis we'll see in the next slide. Before that, we will go through the case scenario. This is a young boy, 3.5 years boy, who has presented with typical features, atypical features, I should say, atypical features of acute febrile illness, abdominal distension, and then his counts revealed that there is some hematological disturbance in a mild anemia. Hello? Yeah, so it is some hematological, when you look at the CBP, you can make out there is some hematological disturbance ongoing, mild anemia, mild thrombocytopenia, mild leukopenia. When they did the regular bloods, like then they found that potassium is very high. Then that is when they prompted with the diagnosis, and then with the blood counts being like, disturbed, they took the hemato-oncology consultation, and ultimately the child got diagnosed as a Burkitt's leukemia. So this is a case of Burkitt's leukemia. As I just said, Burkitt's leukemia comes under high risk category, where they get treated as like, high risk for the tumor lysis. They are highly prone for tumor lysis. You can see that there is a classical disturbance of the biochemical parameters. Potassium is very high, uric acid is very high, and its creatinine and renal disturbance is already there. Creatinine is very high, urea is very high. So tumor lysis is defined as hyperkalemia, hyperuricemia, hyperphosphatemia, and hypocalcemia. This child also had hypocalcemia. So hyperkalemia, hyperuricemia, hyperphosphatemia, and hyperkalemia, whenever you see this combination, immediately you need to look at, is there any significant renal disturbance? What is the urine output of the child? So that nursing aspects, Sister Vijayalakshmi also will mention to you. And accordingly, we have to go ahead and treat them. So this child, like, how do we manage tumor lysis? So for whenever you see disturbance like hyperkalemia, hyperphosphatemia, hyperuricemia, first and foremost treatment should be hydration. So hydration, you have to hydrate the child well. You have to give 2.5 liters per meter square. That is doctor's job to calculate how much of fluids to give and then start. Your nursing aspect is like, you have to ensure that there is a good working cannula to run the fluids so that it is not getting tissued or it is not getting extravasated. And then try to minimize the disturbance in disconnecting the cannulas, whenever they are getting agitated or they want to get disconnected from the fluids. Try to minimize that period. We can't say that they can't get disconnected at all. We have to do that, but we have to minimize that time because most of the times we have to run the thorough hydration for them. We need to treat the hyperkalemia. There are various methods of treating hyperkalemia. I am sure you all would have seen in your units. And you have to treat hyperphosphatemia. Most important aspect, what you need to go ahead and remember is you don't treat hypocalcemia aggressively. Because hypocalcemia, if you treat aggressively without symptoms being there, it can precipitate the renal obstruction and renal failure, renal crystal formation. Going by that, don't treat the hypocalcemia aggressively. So treat hyperkalemia, treat hyperphosphatemia, treat hyperuricemia. Hyperuricemia also you must be aware, like, treat with the agents like allopurinol, raspberry case and all. And you have to go ahead and monitor the output strictly and then take care of the child. Just to highlight the certain nursing aspects, our sister Vijayalakshmi is with me. She is going to add few comments from her side.
Good evening to all. Tumor lysis syndrome, initial phase of diagnosis. Make sure they checking vitals frequently. Strictly monitor urine output chart. Monitor conscious level. Make sure hydration with 125%. Make sure patient currently taking medicine, especially allopurinol tablet. Regularly to send blood tests like CBP, electrolytes, calcium, uric acid.
And follow the investigation.
Follow the investigation. Inform to doctor also. We should educate to patient attender to personal hygiene, hand hygiene.
Yeah. So as Vijayalakshmi said, it's very important to educate the patient. Otherwise, you are going and repeatedly pricking the child. Child is just brand new, no central line to do the bloods. You are doing the blood test frequently. So you have to educate the patient why you are doing it frequently. Yes, our doctor would have done that. But definitely they will come and ask you because you are the first contact. They will repeatedly come and talk to you why you are pricking repeatedly and all those. So you have to educate them in advance what is the importance of that. So that is how you go ahead and manage the tumor lysis. And then we move to next important oncological emergency, which is febrile neutropenia. This is a typical example you all would have seen, like, either in induction or in consolidation, whenever the child spikes, the first thing what we need to look at is, like, of course, one is stabilization of the child. So second is, like, where they are in the chemotherapy, and obviously that is doctor's job. And from your side, definitely what we do is, like, we give the 24-hour line contact number to the patient. Whenever they call, they always, whenever they are in the induction, consolidation or intensive phase, any delayed intensifications like reinduction, reconsolidation and all, if they are in those kind of intensive phases, we always tell them whenever there is a fever, they have to report immediately. So what is the definition of febrile neutropenia? Most of you might have heard, like, if there is a temperature of 100 degree persisting for more than 100 degree persisting for 1 hour. So then also, like, it with the count less than 500, absolute neutrophil count less than 500, or even if it is a single spike of more than 101 with the counts being less than 500, still it qualifies. Definitely it qualifies for the febrile neutropenia. So as a sister, when you are taking a call in the middle of the night, when you get a call that, from a child who is in intensive phase like induction, consolidation, reinductions, or intensification part. So in those kind of situations, you always have to tell them febrile. We would have educated them in advance, but you also have to realize that at that point of time that febrile neutropenia is an emergency. So definitely they have to seek the medical attention to initiate the treatment as soon as possible. So we have seen what is the febrile neutropenia. Who is prone for febrile neutropenia? Children who are on chemotherapy for acute leukemias like ALL, AML. AML is very high risk because it's very intense treatment. ALL also definitely they are prone for febrile neutropenias. And even solid tumors, intensive chemotherapies like neuroblastomas, Ewing sarcomas, those kind of or high risk other solid tumor treatments. So those kind of treatments definitely can cause count drop and then febrile neutropenia, despite you go ahead and give the GCSF to them. So febrile neutropenia is remember, febrile neutropenia is a medical emergency. It is defined, it is compared to MI, that is myocardial infarction in the adults. So that is like, that requires immediate attention. So in febrile neutropenia, whenever you are handling, what we have to, so, we have decided that it is a febrile neutropenia, it requires emergency treatment. They have come to ER or they have come to oncology ward because you are in touch with them for the long time. So when they have come to you, then what next you have to do? First thing is, we all know that we check the vitals, stabilize the child, airway, breathing, circulation. Then followed by that, we have to collect the blood culture, do blood counts, CRP and electrolytes and biochemistry part. Like, we also have to go ahead and check. And initiate the broad spectrum antibiotic as soon as possible. So broad spectrum antibiotic policy differs from unit to unit. You have to choose the antibiotic according to your unit policy as per the antimicrobial flora sensitivity pattern. What is the flora in that area and what is the sensitivity pattern according to your antibiogram? What we call it as antibiogram is nothing but in last 6 months, what are the different bugs you have grown and what is the sensitivity of those bugs? They decide, and accordingly your unit in charge doctor, unit head will decide what should be the first line for high risk febrile neutropenia cases or intermediate risk febrile neutropenia cases or low risk febrile neutropenia cases. You should have a SOP written up and then you have to initiate the antibiotics accordingly. And once you start the antibiotics, when to stop, following the culture, when to stop, how to monitor the counts, how to monitor the other agents like CRP, all those things, you should be aware. But doctor will take care, but you also, if you are also aware of it, then it is well and good. So that is how you choose, like, which antibiotic to start and then what are the important bloods to collect. And then other things in febrile neutropenia I have to mention is next is enterocolitis. So a child, this is very, very important aspect. I want most of the nursing staff to be like, aware of, because enterocolitis is like that is also similar to febrile neutropenia, especially neutropenic enterocolitis is a big emergency. So neutropenic enterocolitis, how will it present? It will have fever, febrile, and it will have low counts, abdominal distension. Sometimes fever may not be there, abdominal distension, tense abdomen, bowel sounds will be reduced, low counts will be there, vomitings may be there. So all those, like, if you pick up early, like, you may not have all the features like abdominal distension, reduced bowel sounds, vomitings, tense abdomen, shiny abdomen. You don't have all, but you have one or two, and then you pick up. At that time, it is well and good. But these are the various signs what I just mentioned. So if you have any of these signs along with low counts, definitely you have to go ahead and put the child nil by mouth. So in the middle of the night, when you are on call and child is vomiting, low counts are there, when they take something orally, getting intense, severe pain in abdomen, so you know that there is a enterocolitis that is active. So you have to go ahead and keep them nil by mouth, initiate the antibiotics. You would have sent the cultures already. So keeping nil by mouth, putting the NG tube down, doing continuous aspiration, initiating broad spectrum antibiotics, and monitoring the counts and cultures. These are the important aspects of enterocolitis management. At the same time, we also have to remember that we should not go ahead and put the suppositories. If we put suppositories for them, we know that with low counts. So what is the process whenever you give chemotherapy? Chemotherapy not only acting on your cancer cell, also acting on the normal tissues of the body like gut and hair, liver, skin, various parts, and most importantly, most importantly, hematopoietic system, that is bone marrow. So it drops the count. It affects the gut. So mucositis will be there. Mucositis will be there. So mucositis, and that can attract the gram-negative bacteria which is there in the gut into the circulation, causes febrile neutropenia. All these series of events happen. So whenever you have a neutropenic child who is febrile or afebrile, if you give suppository, already your mucosa is inflamed or disrupted. If you put something, then it can cause migration of more gram-negative into circulation and can aggravate the febrile neutropenia. So you need to be careful in handling those febrile neutropenia children. So we all know that hand hygiene is utmost important. Sister Vijay Lakshmi will tell you about the importance of hand hygiene. That is one important aspect to control the infections, especially transmission of your, gut colonizers from one patient to another patient, also other organisms. She will tell you nursing aspects of hand hygiene and other precautions.
While assessing child to maintain hand hygiene, whenever opening line to maintain aseptic technique with using hand rub or a back rub solution. Frequently hand washing, maintaining hand washing. We are using 6 steps of hand washing and hands moment, hand hygiene of moment of hand hygiene. Antiseptic solution we are using hand rub, back rub to
prevent the infections. Yeah. So mainly we have to maintain the hand hygiene to control the number of infections. We all know that. And line care, CLABSI, central line associated bacterial infection, which is called as CLABSI. That also we have to go ahead and control by taking care, by handling the line is in an aseptic way. Some of the patients will go to the local hospital, get a line, which happens very rare because most of our patients, we know that once we start the treatment, they do come back to us, but at times they can go to local hospitals and they may not handle the line properly, and CLABSI is one of the big problems. And other than that, your own flora can go and sit as a commensal and can become a pathogen whenever you go neutropenic. So that threat is also there. I have put up these IDSA guidelines. I don't think you need all these. This is for doctors to remember. I'm skipping this case and moving on to the next case. So I think you all understood febrile neutropenia as a medical emergency. Hand hygiene is most important thing what we need to take care to control the infections. And we also need to make sure that the people are like caregivers also should not have active infection because they can transmit to the child who is in contact directly for longer periods. So we have to ensure that, caregiver is also not having significant infections. And we always try to vaccinate the caregivers in our unit. Are not only the medical personnel, also caregivers need to get vaccinated so that they don't get into bad infections and transmit infections to our kids. And then, so this is another oncological emergency is seizure. Whenever we see seizure, what are the precautions we take? So what are the nursing aspects we have to remember? Main 3 important nursing aspects. So you want to say 3 important nursing aspects. One is like, most.
Hello, good afternoon, ma'am.
First is preventing injury. Always like look around, like, where is the child? Is it, is she or he at the end of the bed? Put them into safe position, prevent the injury. And second aspect is protect the airway. So you have to turn them to the side so that they don't aspirate their own secretions. Okay. And then third is like, maintain the privacy, put the curtain around, and then take the help of the other medical personnel. So you should have a doctor as a lead and other sister helping you constantly in loading the medications and administering medications to the child, whatever you are asking. We all know that we have to give midazolam spray to abort the seizure immediately. We have to give Levipil or other agents as per your unit policy. Generally, we use either Levipil or lacosamide because they don't interfere with the chemotherapy agents. So we all know that those are the medications, but first three aspects are very important: prevent the injury, protect the airway, maintain the privacy. 3 P's are very important, and followed by you are looking at the cause of the seizure. These are the various case scenarios I have put up. One is where this child, what you can see in the CT scan, like various here you can say these are the deposits. They are not supposed to be there naturally. These deposits indicates that there is a brain parenchyma is studied with the lesions. So it's a high count ALL. This child had 8 lakh WBC. We all would have seen 1 lakh, 2 lakh, 3 lakh. Sometimes this child had 8 lakh WBC. With that, CNS is studied with the lesion and he presented with seizure. That can be one of the cause. So that also one is that can cause seizure and that can cause 2 more oncological emergencies. One is hyperleukocytosis, CNS stasis, seizures, hemorrhagic infarct. So, and another oncological emergency with 8 lakh count is tumor lysis. So, these kind of scenarios, you should be careful with the infections, tumor lysis, seizures, hyperleukocytosis, various aspects. And this is another important message you all have to carry. Whenever a child gets into seizure, you have done your protection of airway, you have maintained the privacy, you have prevented the injury, you have loaded with medications. Then at the same time, what is the important thing you need to look at is blood pressures. So blood pressure, sugars, biochemistry like calcium, magnesium, counts, all those things you would have checked. But in addition to that, blood pressure, checking the blood pressure is very important. This oncological emergency usually happens in induction, that is first month, where your dono and steroid combination causes press. So this kind of scenario, with a high blood pressure, definitely requires management of the high blood pressures rather than, just giving the anti-epileptics alone. So, and this is a methotrexate toxicity. Many of you would have seen this. Usually this happens in the second month. So when the child is in consolidation phase, usually 5 to 10 days post intrathecal methotrexate. It happens more with intrathecal, less with intravenous, but with intravenous also it can happen more with intrathecal methotrexate in the second month, 5 to 10 days post. They can have various features like monoparesis, aphasia, seizures, so or transient locked-in kind of syndrome. So these kind of various features can occur with the methotrexate toxicity in the child. When to do the giving anti-epileptics, anti-edema measures, doing MRI, all these are doctor's decision. So when to do, what to initiate, how long to give, how many months are here. So that will be taken care in the follow-up. But the immediate aspects are same what I just mentioned, all the protective measures we have to do. And another oncological emergency that can cause seizures is superior sagittal sinus thrombosis secondary to PEG asparginase. So PEG asparginase and steroid combination, especially PEG asparginase, can cause thrombotic tendency in the body, and that can result in cortical sinus venous thrombosis. That is that can happen in transverse sinus, superior sagittal sinus, various sinuses, and can cause seizures. So usually it causes hemorrhagic infarct, seizures, and generally here the child will be little more sick. Here child will be more sick, in press also more sick compared to methotrexate toxicity. Usually the recovery will be faster in methotrexate toxicity. And on the other hand, other causes of seizures, what we all need to remember is like infection and bleeding. So especially the child is in first month, second month, they are more prone for very low platelet count It can happen even in the delayed intensification also, but more we see in first and second month. So the bleeding in the CNS is another important differential whenever child goes through seizure. And other differential what we need to think of is it an infection that is causing seizure? Meningitis with or without infarcts also can cause problems with the seizure. So as a nursing staff, you always have to remember that, to stabilize the child, to whenever you are doing investigations, like, are we supposed to do lumbar puncture also in the same sitting to rule out CNS infections or any other problems, especially when you are doing in the first diagnosis along with we do bone marrow diagnose them, later we do the lumbar puncture, we document the CNS disease part. So that follow-up of that is very important. Like, after a week, whenever you are CNS positive and you are doing lumbar puncture and giving the intrathecal, that time always remember to collect the CSF to check the follow-up of the blast what you have in the beginning. You may have to recommend to your doctor, like as a smart nurse, okay, whenever you're doing lumbar puncture to give intrathecal, do you want to collect the CSF at the same time? Do you need sample for any investigations? As a smart nurse, you just have to, remind your doctor. So these are the various oncological emergencies. I'll hand over to our colleague, Dr. Varshini. She will tell other oncological emergencies. Sorry for the delay because we started late, so that's why we are going ahead little late. This is just an example for hemorrhagic cystitis whenever you are giving ifosfamide or cyclophosphamide. Hemorrhagic cystitis is one of the oncological emergency. What we see, these are important problems what we need to take care to improve the long-term outcomes in our children. Yeah, so let's look at the other aspects.
Good evening, everyone. Can you hear me?
Yes, ma'am, you are audible.
Thank you. I hope you are all having a good session. Ma'am have covered most of the important oncological emergencies and elaborated very well about importance of febrile neutropenia, which we need to be really very much careful in our oncological kids. So I will be covering now the obstructive causes of other leading to oncological emergencies. The first one. So this is actually
Ma'am, I would request you to just put it on presentation board because
yeah, sure.
yeah, this is not visible.
Yeah, is it visible now?
Yes, ma'am. Thank you. You can proceed.
So coming to this first scenario, there is actually a 7-year-old boy who presented with cough for 2 weeks, respiratory distress for 2 days, and puffiness of face. And when we have examined, there is conjunctival redness, venous engorgement over the chest. And the vitals wise, there is tachypnea, that is respiratory rate is 44 per minute, which is high for 7-year-old boy. Heart rate is high, 120 per minute, and saturations are 88% at room air. And the blood pressures are 124/76. So this is the picture, if you can see. So there is a right side a facial puffiness, and he is not able to open his eyelids also with the puffiness over the neck region causing edema. And in the X-ray, you could see the hard shadow will be left, but even on the right side, there is whitening. So there is something within the chest. So this is something called superior mediastinal syndrome. So where a mass within your chest causes compression over your vital structures leading to this syndrome. So superior vena cava syndrome is a part of superior mediastinal syndrome where there is a compression of the superior vena cava or else a thrombosis leading to the symptoms of compression. And the mediastinal syndrome is nothing but superior vena cava syndrome with brachial compression causing breathing difficulty and respiratory distress. So these both terms are generally interchangeable in the children. Yes, so what are the causes? Mainly the tumors, solid tumors, lymphomas, or else any T-cell ALL with mass in the mediastinum, germ cell tumors, lymph nodal mass, sometimes benign tumors also cause. And the other cause is any thrombosis of the superior vena cava catheter. So predominantly anterior mediastinal masses cause all these symptoms. So what are the signs and symptoms which we should see? Face and neck swellings, shortness of breath, chest pain, dry cough, cyanosis, nasal congestion, hoarseness of voice, and difficulty in swallowing. And as you can see in the picture also, there will be venous engorgement leading to distension of your thoracic veins and neck veins. Why is it very important? Because it causes respiratory distress, tracheal compression, so breathing difficulty. So we need to put the patient in a comfort position where the obstruction is relieved. So head up position, at least up to 45 degrees needs to be done. IV line placement should not be done in the upper limbs in such cases. Only we need to preferably use lower limbs. Generally, we don't prefer lower limbs, but in this scenario, we prefer lower limbs. We need to put them on oxygen, supplemental oxygen. And then as a decompressive measures, IV diuretics we start. And if we see any catheter, indwelling catheter, SPC catheter, we need to immediately remove that. And any thrombosis, we need to attempt to give anticoagulants or thrombolytics as per need. And the main thing is we need to establish diagnosis in these kids. So as a routine, we cannot give sedation in these children. So we can't give this midazolam or during bone marrow procedures, most of us give midazolam, ketamine, or any other procedures. So we have to avoid any kind of general sedation in these kids. Why? Because already there is a tracheal compression, and on giving general sedation, there will be compromise in the respiration and the child can deteriorate. So leading to even tracheostomy. Intubation also might not help in them. So we should strictly avoid sedation in these kids, especially when the child is in ICU. We need to mention to the sisters. Under local anesthesia, image-guided FNAC can be done. Okay, so the main initial goal is treat the life-threatening symptoms. So the sister in charge need to look at the ABCDE, that is airway, breathing, circulation, and disability and exposure, supplemental oxygen, positioning of the child, adequate hydration. Here, we can't give higher amount of hydration to prevent hemolysis because of, again, the fluid overload can cause compression. And once the if the distress is severe enough, we can attempt giving steroids, but we need to plan definitive diagnosis of biopsy within 24 hours of initiation of our treatment. And once we get the diagnosis, treatment as per the protocol. And in some situations, in an emergency, we can give emergency radiotherapy, but very less likely we use this one. And once we start the treatment, usually it relieves by 7 to 10 days of chemotherapy. So what is the role of sister in such cases is ABCDE approach. That is, so for any case, this approach, if you keep in your mind, that is ABCD approach, you can things can be made very easy. The sister will explain.
Assessment ABCDE approaches. A for airway, airway is clear or maintainable. B for breathing pattern. C for circulation. D for disability. Check for pupil, conscious level, weakness. E for exposure.
So the simple alphabets, if we remember, then we won't miss anything in a patient. So we need to always remember this approach. This is another compression. So 1.5-year-old female child was brought in suddenly with the inability to bear weight on the lower limbs and difficulty in sitting without support and back pain since 3 days. How she explains back pain, irritability, crying excessively. In this way, child was expressing. So on examination and bilateral lower limb hypotonia or reflexia is present, bloods were normal, and as MRI spine is done. And here you can see this is a mass. So this is causing the compression of the spine and leading to all these symptoms. This is something called as acute spinal compression. So it is defined as compression or displacement or encasement around the thecal sac surrounding the spinal cord. So this causes severe pain and various neurological deficits. It is an emergency because if it prolongs, then the neurological deficits can become permanent. If we can address it early, so we can reverse these neurological deficits. That's why it becomes an emergency. Main causes are your sarcomas, which cause more than 50% of spinal compressions, the neuroblastomas, lymphomas, Ewing sarcomas, vertebral bony mets, etc. Along with your spinal tumors like astrocytomas, spinal cord tumors, all these things can cause spinal cord compression. So how do they present? They present with severe back pain, especially more worse at night or when the child lays down flat, weakness, gait abnormalities. Abnormally, they walk, their walking will be different. Bowel and bladder dysfunction, that is involuntarily they might pass urine or they might not pass urine. The incontinence, stool incontinence can be happening. Numbness, tingling sensation, and decreased ability to differentiate between dull and sharp pain. And finally, weakness leading to your paraplegia or quadriplegia. So that diagnosis is by MRI and finally biopsy. So what is the initial treatment to relieve the spinal compression is glucocorticoids at high dose, that is high dose dexamethasone can be used to reduce the cord edema. Sometimes surgery can be done, attempted to laminectomy or an emergency radiotherapy. And the definitive treatment will be chemotherapy as per the protocol. Neurorehabilitation and surgery and radiotherapies are the definitive. So here what I wanted to mention is, so if somebody has a paralysis or weakness of the limbs, then the sister should think once and twice before placing any cannulation. So we should not put a cannula in a paralyzed limb because that causes thromboembolic risk increases. So always remember that you should never use a paralyzed hand for cannulation. Okay. So once we identify and treat, then immediately we can rectify the symptoms and the neurological deficits can be reversed. So other thing already madam has covered, it is PRES. So posterior reversible leukoencephalopathy syndrome. It is a swelling within the brain causing secondary to hypertension by most of the drugs which we use like steroids, immunosuppressive agents like cyclosporine or any cytotoxic agents. So headache, they present with headache, vision changes. So sometimes sisters are the first person whom they communicate with. So the mother comes and says, my child sees something black spots or he's not seeing me properly. He's not able to see the things properly. Then you need to get alerted and then immediately tell. And seizures, as my madam mentioned, any confusion, weakness, or weakness of one or more limbs. So first and foremost is, first of all, we need to discontinue causative drugs. Sufficient hydration, oxygenation needs to be given. We need to correct the hypoglycemia, electrolyte disturbances, and coagulopathy. And gradual reduction in blood pressure. The blood pressure drop should not be very acute. It should be a gradual thing. And anticonvulsants for seizure. So as madam mentioned, so while managing any acute event, so it will be definitely a team effort. So who has first identified the issue, immediately do whatever you can rescue the child and then call for help. Then don't get panicked by the situation. One of the sisters should lead the situation and then she should pass on the orders so that the other sisters will help in getting the things. So suppose a child has a seizure. So immediately you need to start oxygen bedside and change the position to left lateral or right lateral position so that there won't be any vomiting, aspiration or any injury to the child. Then you need to call for help, and most of all the units will have a crash trolley, okay, where all your things will be available to for any emergency situation. So you need to bring that your crash trolley to your bedside, and whatever is necessary, meanwhile doctors will pitch in, and then when they say orders, rather than running for everything, you can simply coolly and calmly deal with the situation. Panicking with the situation should not happen in any emergency. So you need to keep your presence of mind and deal with the things in a cool and calm way. So next most important thing for a nurse is extravasation. I think before the talk started, Dharani madam has started about this one. So extravasation is the accidental leakage or infiltration of intravenous drugs into the surrounding tissues from the vein. So what happens? This causes some inflammatory, painful reactions and leading to local tissue destructions and complications. So it is again divided based on the type of drug. So vesicant drugs, again, there are two types: DNA binding kind, that is daunorubicin, doxorubicin, sapirubicin, dactomycin, or non-DNA binding, vinblastine, vincristine, doxycycline, paclitaxel, simple irritants like our platins, cytarabines, fluorouracils, methotrexate, others like bleomycin, etoposide, and simple inflammations are other normal drugs and neutral drugs. So what happens is these mainly DNA binding vesicants cause damage to the DNA and free radical release and damage to the tissue. Non-DNA binding, they interfere with the mitosis and they cause the damage. Whatever it is, they cause damage to the tissue and it forms as a dead tissue. So what are the main risk factors here? Repeated intravenous cannulations or venipectures into the same vein or cannulations into fragile veins in thrombocytic patients. And vesicant properties of the drug needs to be carefully learned, and we should know the exact dilution, what concentration we have to give, and what administration time we need to know. Prolonged peripheral line infusions generally cause vesication, and iatrogenic causes like poor cannula size, poor improper location, and giving them very fastly without proper flesh, all these things can lead to extravasation. So prevention is always better than treating them. So how do we prevent? So during vesicant administration, every day, in fact, not only during vesicant, every day, once you take every shift, the sister changes. Along with the over you take from the previous person, you need even first go to your patient, check the cannula site, how is it? Okay, any swelling, redness, or pain. Then once you are administering the drugs, you need to properly dilute and it should be administered in specific time as mentioned. And the IV lines, once we are using it, before and after we need to flush it with a proper NS. And daily monitoring of cannula site, appropriate vascular access. That is, we should select the veins, the smaller bore in a larger vein and fresh veins. We need to see if at all we don't have a central line, and patient and parent education also about the line care, because lot of movement of the cannula also can lead to phlebitis. Avoiding lower limbs for cannulation and documentation and proper reporting of extravasation injury. And everyone should maintain an extravasation kit rather than running at that time. So we have a disposable syringes, cannulas, hot and cold packs, gauze pads, sterile gloves, and medications sometimes required like hyaluronidase, DMSO, and dextrose. So the clinical features are burning, stinging pain, swelling, erythema or induration around the skin, and finally blister formation and necrosis. So this can be graded of extravasation graded 1, 2, 3, 4, 5. Okay, so now no extravasation, only erythema with pain and induration, ulceration or necrosis with tissue damage, or life-threatening event, and finally death. So this is the extravasation injuries pictures. So the treatment is, first of all, stop the infusion immediately, but don't remove the cannula. If it is a chemotherapy drug, vesicant drug or something, try to aspirate as much of the drug as possible with a 10 ml syringe. And as we discussed, collect the extravasation kit, and based on the drug we have given, you use that kit. And if it is not a vesicant drug, we generally in our unit policy, we some extravasation happen, we try to give a hydrocot into that cannula and remove the cannula and administer pain relief as required. Simple paracetamol also can help. So here main note is two type of drugs. Vinca alkaloids are the only drugs like vincristine, vinblastine, where you need to give warm compressions, hot. Heat should be given for 20 minutes, 4 times daily for 1 to 2 days. Okay, so how do we remember Vinca? Warm for Vinca. So if you keep this one in mind, so the rest of all medications, other vesicants, extravasation, we can give cold compressions for 20 minutes, 4 times daily for 1 to 2 days. And this will limit the cellular uptake of the drug and lesser damage will happen to the tissue. This is a flow chart. And a simple elevation of the limb and applying hydrocortisone cream or 1% cream every 6th hourly for 1 to 7 days as long as the erythema persists. So other drugs, if it is severe enough, then the doctor will be telling you to administer the hyaluronidase or DMSO if it is available. as and when required. Thank you. Actually, we thought of even discussing much about the bleeding problem and then how to administer the blood products, but because of the time constraints, we are already past the time. So probably in the next session, we can in detail discuss about the bleeding and the blood product transfusion and reactions.
Yeah, thank you. Thank you, Varshini, and thank you, Sirisha ma'am. Thank you, Mr. Jayalakshmi. It was a wonderful and comprehensive session. I know we can keep discussing, but probably we'll have a detailed session, like you said, in one more next month, probably. So, any questions or comments from anyone? I would say I think the practical points and the nursing perspectives have been very well covered. I sincerely thank both of you. Sorry for the technical glitches to begin with. To take your time out of your busy schedule and do this so meticulously. If there are no comments or questions, Pashni, you want to add anything?
So nothing. I think hope everyone understood what we tried to say. The mainly thing is sisters are the first person to deal with any of the emergency rather than any other doctor. So you need to know about all these things, though not in detail. So what is the immediate emergency step which you can do? You can handle the situation, and then once we come up, the situations will be better taken care. So hand hygiene is one very, very, very important thing where most of the infections can be under control. So in a hurry, most of the times the sisters run from one patient to another patient and doesn't realize that they're not using the hand rub. Though they know all the steps and everything, still they forget because in a hurry, in a thing, they forget it. But it should be a habit. Once you go to the patient, immediately your hand needs to go to your hand rub, click it immediately, at least for a few seconds. If you rub with your hand rub also, that also try to reduce most of the infections. And any questions, anything, we are happy to take, but I think there's no question, and probably we can cover it much better in next session in other topics.
Sure, we'll get back on that. Very well mentioned point. Yeah, prevention is always better than cure. So prevent the infection, especially in this era of multi-drug resistant organisms. It's always better to have the hygiene followed. With this, I thank your team, Sirisha ma'am, Dr. Vashini, and Vijay Lakshmi for a wonderful session. And we close the session with this. I hand over to Manisha.
Thank you.
Thank you so much. Thank you everyone for joining us today. And it was a wonderful session. And I would request all the participants to I will share the feedback link on the chat box, and you can fill this feedback form and share your feedback for this particular session. Thank you everyone. I'll be sharing the link in few minutes.
Thank you.
Thank you. Thank you so much. We will be waiting for 4-5 minutes. Meanwhile, you can click on this link and submit your feedback.